Total fluid bolus can go up to 60 ml per kg. Now, if you are in a setup where ICU facility is not available, then if a child has come to you in compensated shock, you will not give fluid bolus, but monitor the child very closely. If the child has come to in hypotensive shock, you will give a bolus of 10 to 20 ml per kg, and the total bolus volume should not be more than 40 ml per kg. So, what is the volume of fluid to be given also depends on the type of shock that you are dealing with. Now, if the child is a hypotensive shock, you will give isotonic crystalloid fluid 20 ml per kg using push-pull technique if there is evidence of loss of fluid. If the child is in compensated shock, you will give the same volume but over a longer period of time with close monitoring. Most important thing is if the child is in cardiogenic shock. So if the child is in cardiogenic shock, you'll give a very small amount, 5 ml per kg, over a longer period of time, 30 or 45 minutes, and strictly monitor for any signs of fluid overload. At any point of time, you feel the child is worsening in terms of increase in the size of liver, worsening distress, or developing crepes, then you will stop the fluid bolus. So what are the fluids that we can use? So there are broadly crystalloids and colloids. Crystalloids are usually the first choice of fluid for resuscitation as it is cheaply available and readily available. But what are the disadvantages with crystalloids is it gets rapidly distributed across the intravascular and the interstitial space. And you require more volume of fluid for the same amount of intravascular volume expansion as compared to the colloids. Also, the effect with crystalloids is very short lasting. Now, colloids gives a greater and more sustained increase in the intravascular volume, but it is expensive and not so readily available. So the first choice of fluid when it comes to a child in shock for resuscitation will always be crystalloids. Unless you have a child who has come to you in hemorrhagic shock or trauma patient, then your blood becomes the first choice of fluid. Till blood comes in, you can give crystalloids. So what are the problems associated with excessive fluid administration? So it is seen that excessive fluid administration gives rise to there are higher chances of heart failure, increased ICU stay, increased mortality, increased need for mechanical ventilation, and increase in the ICU days. So coming to the role of POCUS in child with shock. So we use point of care ultrasound for screening of heart for function as well as dilated chambers, visualizing the IVC, screening of lungs, and for EFAST. So EFAST is used in trauma patients. It is extended focus assessment with sonography in trauma. So we'll come to each of the scenarios now. So first thing, if you have POCUS features which show collapsed IVC with absent B lines with hyperdynamic heart. So all of these features are suggestive of a preload dependent state. As in, you need to push in more fluids in the child. So you'll give fluid bolus. So this is how we'll place the cardiac probe in the patient and the echo findings. So you will see that the IVC is lesser in diameter and with each inspiration it is getting collapsed. Also, if you can see, the heart is quite hyperdynamic. So this patient needs more fluids. Second example is if you have a distended IVC, multiple B lines, poor ventricular function with dilated chambers, all of these features are suggestive of cardiac dysfunction. What you have to do is fluid restriction, start in vasoactive agents, it could be adrenaline or dobutamine, and start Lasix only after the perfusion has been stabilized. So in this video, we can see B lines. So the first picture, what you can see are the A lines, and the second picture are the B lines. So A lines are the horizontal lines and B lines are the vertical lines. So this child has got confluent B lines. And in the second video, we will see the IVC is dilated, and from little bit heart that we can see, it looks like it's not contracting very well. So this is a dilated IVC. Okay. Next, if you find positive EFAST images, so we'll come to each one subsequently. Positive EFAST is suggestive of anytime we need to give blood transfusion and do damage control resuscitation. So EFAST what are the various pro positions from where we can do e-fast? There is right and left anterior chest, which will help us in ruling out pneumothorax. Right upper quadrant and left upper quadrant, which will help us in seeing if there is fluid accumulated there. Subxiphoid view to rule out pericardial effusion, and suprapubic to rule out again peritoneal free fluid. So this is the proposition. This is for right and left anterior chest view. This is for subxiphoid view. This is for suprapubic view. And this is for right and left upper quadrant views. So in this USG, we can see this is the lung field. So the shining bright line over here, this is the pleura. And below that, this is the lung. This is the chest wall. So if we put M mode across this, the upper part is the immobile chest wall and the lower part is the sliding pleura with sliding lung below it. So this is the typical seashore sign which is seen normally in normal patients. So coming to the next slide. So this slide shows us pneumothorax. Now if you put a M mode across a normal lung, you will get the seashore sign. If you put it in a child with pneumothorax, you will see a barcode or stratosphere sign. So upper part is the immobile chest wall and lower part is again immobile lung because there is no movement there because of the pneumothorax. Other thing that we have to see on POCUS is the lung point. So lung point is the point where you will see the moving sliding pleura and the moving lung below it and non-moving mobile pleura. So the point where they both meet is the lung point, and this, if you are able to find, is almost always suggestive of pneumothorax. So coming to the right upper quadrant view, in the right upper quadrant view, you will be able to see the Morrison's pouch, which is the hepatorenal pouch. Normally, there is no fluid between the liver and the kidney. But if you see fluid, it is suggestive of peritoneal free fluid. So there is fluid in the hepatorenal pouch over here. This is the left upper quadrant view, kidney and the spleen. Again, there is no fluid in between. Here you can see fluid accumulated above the spleen. So first area where you will see fluid accumulation in the left upper quadrant is above the spleen. So we need to make sure that we include this area also when we are screening the left upper quadrant. After the fluid gets accumulated above the spleen, it will go between the spleen and the kidneys. Next view is the subxiphoid view. Here you will try to visualize the heart. So this is the normal four chamber view and there is no effusion over here. In the second picture, you can see there is pericardial effusion. Last, coming to the suprapubic view, you will see bladder with and two paracoid gutters are surrounding it. In the second picture, you can see there is accumulation of free fluid near the bladder. Coming to the last slide, anaphylactic shock. So if a child comes in to you with anaphylactic shock, so anaphylactic shock is a type of distributive shock. So you will give crystalloid for volume expansion. IM epinephrine dose will be 0.1 mg per kg. Dilution of 1 in 1000, that is 1 ml is 1 mg of adrenaline. Max dose is 0.5 mg. You will give maximum 2 doses of this IM epinephrine, and to remember not to give subcutaneous epinephrine because when the child comes to in shock, he will be severely vasoconstricted. If you give subcutaneous vasopressin, it will not. If you give subcutaneous epinephrine, it won't get absorbed into the circulation. So we have to give it IM. If with 2 doses the shock doesn't get resolved, we'll have to start the child on continuous infusion of adrenaline. Along with this, we also have to give a dose of hydrocortisone or MPS. If on auscultation you find there is bronchospasm, nebulize with bronchodilators. So this is in short about management of shock at the ER level. Coming to the second topic, approach to a child with dehydration in ER. So again, we'll start with introduction, classify the diarrhea, see the hydration and the nutritional status, diagnostic tests and management at ER level. So diarrhea is the leading cause of childhood death in the world, accounting for 5 to 10 million deaths per year. In early childhood, rotavirus is the most important cause of diarrhea. Other viruses like estro, calci, noroviruses are also important. So when we do clinical assessment, we have to see what is the type of the diarrheal illness, what is the hydration status, nutritional status, and see for any comorbid conditions. So classification of diarrhea is based on the history of duration, frequency, and character of diarrhea. So acute watery diarrhea, you have loose watery stools in at least 3 times in a 24-hour period. Invasive diarrhea or dysentery will come with fever, with blood and mucus in stools, which is due to inflammation of the distal small bowel and colonic mucosa in response to the bacterial invasion. Persistent diarrhea will last for more than 14 days. What we need to pay attention to is cholera, which will also have acute history, and child will come with very severe dehydration and typical rice water stools. So here we can see the first image is greenish stools which are typical of rotavirus. The second one is white rice watery stools which are typical of cholera. And in the second image over here, this is suggestive of invasive diarrhea. So assessment of hydration status. So death due to dehydration is an important cause of mortality in resource limited settings. And mostly the death is because we end up underestimating the amount of dehydration, and also the ongoing fluid loss is underappreciated. So there are two ways of assessing the hydration status, calculated assessment and the clinical assessment. The more precise way of doing it is the calculated assessment, but for this we need the pre-illness weight, which might not be available with us. So the formula is percentage dehydration is pre-illness weight minus illness weight divided by pre-illness weight into 100. What we usually follow is clinical assessment. Here each 1% of dehydration corresponds to 10 ml per kg of fluid deficit. So how do we do it? So on examination, we'll see it's divided into mild, moderate and severe. On examination, we'll see the following components. Skin turgor, how does skin feel to touch? Buccal mucosa, lips, eyes, tears, fontanelle, mental status, pulse rate, pulse quality, CRP and the urine output. Based on this, we'll divide the child as mild, moderate and severe dehydration. So in infants, we take it as 5, 10 and 15%, and in older children, 3, 6 and 9%. So these are the various signs that we'll see. Now, why nutritional assessment is important? So children with acute diarrhea and malnutrition are at increased risk of developing fluid overload and heart failure while you are treating the child. Also, they have risk of serious infection. That is why we need to keep these things in mind. Now, diagnostic tests which are important at the ER level are electrolytes and sugars. So, if the child comes with seizures or altered sensorium, we need to see electrolytes and the sugars. Now, the management will go in 2 phases, replacement and maintenance phase. And it's very important to note that both have to be started simultaneously. So, first is plan A, which is no dehydration. So, children with no dehydration do not require hospital admission. They can be sent home, but after a brief period of observation. You will see whether the child is vomiting or whether he's taking well orally. So here, what are the fluids that you will advise at home? So you can give ORS, you can give salted drinks like salted rice water or salted yogurt. You can give soup, you can give coconut water. But what is not acceptable is carbonated beverages, sweetened juices, coffee, tea, or medicated infusions. This is not advised. If you want to give ORS replacement, you will give it as 10 ml per kg per episode of loose stools. If the stool output is not very high, ORS may not be necessary. You can just continue feeding and give supplemental fluids. Second, coming to plan B, which is some dehydration. Here you will give 75 ml per kg of fluid over the next 4 hours. So this replacement can be either through IV or through oral route. If the child is taking well orally, you can just give ORS over the 4 hours and monitor the child. So after 4 hours, again you will reassess the child fully and see if the signs of dehydration have worsened. So if the signs of dehydration have worsened, you will start treatment as per plan C, which is for severe dehydration. If the signs of dehydration have improved, you will go back to plan A. Coming to the most important type C, plan C, which is severe dehydration. Here your goal is to rehydrate with stabilize the circulation immediately, and you will, if the child is in shock, you will go to the shock protocol and give bolus. So you will rehydrate with 100 ml per kg of isotonic fluid. If the child in 30 ml per kg will go over 1 hour and 70 ml per kg will go over 5 hours. In older children, 30 ml per kg in 30 minutes and 70 ml per kg over the next 2.5 hours. We'll assess the patient every 15 to 30 minutes and see if the radial pulse volume improves. If the hydration status is not improving, we'll just increase the speed of the IV drip. Once the planned amount of fluid has gone, we'll again reassess the child completely. If the child has improved, we'll go to plan B or plan A accordingly. If the child is still severely dehydrated, which is very rarely seen, but common in a patient with cholera, you will again repeat the IV fluids as per plan C. What we can use for rehydration? We'll give isotonic crystalloid fluid with 130 to 154 milliequivalents. The choice of fluid will be balanced crystalloids. Now, what are balanced crystalloids? Balanced crystalloids are isotonic fluids but with a lower chloride content. So, typically, ringer lactate or plasmalide are balanced crystalloids. So, we'll start with the fluid using DNS and replacement using plasmalide or RL. Coming to one slide on zinc. Zinc is very important. It reduces the severity and duration of malaria. Dose is 10 mg per kg for under 6 months and 10 mg per day for 6 months, under 6 months, and 20 mg per day for from 6 months to 5 years for 10 to 14 days each. Next, prevention is very important. So exclusive breastfeeding, hand washing practices, immunization, and safe food and drinking water practices are very important. So coming to the end, thank you.
Good afternoon, everybody. So I'll be taking the last topic of today. So I'll be talking the last topic of today, and that's febrile neutropenia in a child with cancer. And why is this important? This is especially important because you, as primary physicians, as pediatricians and general practitioners, are the first contact point of these children who are on chemotherapy with us in the hospital, but they don't stay all the time with us. They take their chemotherapy and then they go back home. And Bombay being a vast city, they come from some remote areas in the city. So for them, commuting immediately at that very time when they are not doing well is very, very difficult. And in that scenario, you are the first primary contact points for these children. And so they need to get the prompt treatment as far as they need to get the prompt treatment. And for this, I am taking this topic of febrile neutropenia in a child with cancer. So I'm Dr. Preeti Mehta. I'm a senior consultant in pediatric hematology, oncology, and PMT. And I want to give you this case scenario of a 3-year-old child with acute B lymphoblastic leukemia who is on reinduction. So who has finished induction, who has become MRD negative, who has finished consolidation, and now is on reinduction, where we give high dose dexamethasone to these children. And you know that steroids are immunosuppressive, and dexa being more immunosuppressive compared to prednisolone. So this child is on high dose dexamethasone. Now comes to you with lethargy since the last 3 years. The child is slightly tachypnic. The BP is below the 50th centile. The child is drowsy, responding to commands though, listens to you, but goes back to drowsiness. There is no history of fever. The child is residing at Panvel, so he's going to take another 3 years to reach SRCC. That's going to be a span of 6 hours before the child gets any timely help. Now, the patient has come to your hospital or nursing home. What would you do? Would you ask the patient to take a vehicle and come to SRCC? or would you like to do something in the hospital? And this is exactly what I'm going to discuss with you today, that you should be aware of how to tackle this child, even though the child is on chemotherapy. We are always at a phone call away, so we can always coordinate their treatment. But what you as primary nodal physician should be doing for this child. So when a child like this who is on chemotherapy, who is in high dose dexamethasone comes to you, what should quickly run in your mind is, when was the last chemotherapy given? Are some form of steroids going on for this child? If the child has a central line, what is the line site of this child? Is it septic? Is it exuding pus? Is it looking inflamed? Is it looking red or not? Or are there any other symptoms? So this is what we will be discussing today, that febrile neutropenia is a medical emergency, just like a heart attack or stroke, and it cannot be taken lightly. So as I discussed, we discuss about the detailed history which should run through your mind, and then you should be talking to the parents about this. Next is do a hemodynamic assessment, because we don't want to land up in a shock state. But always look, if the child is on steroids, as we saw here, the child did not have fever, but you should look for systemic inflammatory response syndrome signs, and they are like tachycardia, tachypnea, and hypotension. So if anything of this is present, even when the child is not febrile and the child is neutropenic, this should raise an alarm in you. Do a complete physical examination and look for the potential sites of infection. Now, what are these? You look at the skin, the nails, the oropharynx, the gastrointestinal and the respiratory tract, the perianal and the genital regions, vascular access sites, and the biopsy sites, if any. So it goes by a mnemonic known as OSCAR, where O stands for examining the oral cavity. So in a neutropenic child, very, very important to look at the oral cavity, followed by the skin. If there are any breach in the skin, if there's any breach in the skin, the catheter site, most important cause of infection could be the entry site of the catheter. Anal region should be inspected in a neutropenic child, and look at the vital signs as we just discussed. Now, at times, because of the neutropenia, you may not find any signs of inflammation, but you should definitely do all this, and you should look at the line sites, do an oral cavity examination, and look at the periodontium, the pharynx. The abdominal or examination should be basically to see if there's any typhlitis, if there's any tenderness, so the child has gone into a neutropenic colitis or not. Most important, don't do a rectal and a pelvic examination, because a child being neutropenic, you will introduce, it will cause a translocation of the bacteria when you do a examination. So because of the mucositis that they have. So just examine the perineum, but no rectal or pelvic examination. And then you need to categorize whether this child with neutropenia with fever is high risk or low risk. Immediately collect a CBC, LFT, RFT. If the child has a central line, collect blood culture from all the lumens and send paired aerobic and anaerobic blood cultures and a simultaneous peripheral line culture. Now, the rest of the investigation should not be done. You should commence your treatment before doing the rest of the investigation. So it's not a priority to do the swabs and send them for viral and fungal culture, the wound swabs, the urine routine and culture, stool routine, stool culture. All that can be done once you've collected your CBC and blood cultures. If a child has a diarrhea, you can send a stool routine microscopy. Look for Cryptosporidium, Clostridium difficile toxin. And as I said, you don't need to wait to send all this. You should commence your treatment immediately, and then you can later send the stool cultures and the urine routine and urine cultures. If there are respiratory tract infections, if the child can produce sputum, send the sputum or send a nasopharyngeal aspirate and send it for bacterial and viral cultures. So we have to, these children follow the golden hour. That means the child has to receive IV antibiotics within 30 minutes to 1 hour of presentation if the child is high risk. And that's the very reason that you as primary physicians and as nodal physicians have to work fast in these children rather than sending them across to us. But before instituting IV antibiotics, the children should have their baseline CBC and culture sent appropriately from the central lumens and from the peripheral. From each lumen of the central line and from the peripheral culture should be sent. Now, how do you categorize these children as high risk and low risk? So the standard risk, which is the low risk, these children are those ones which are solid tumors, which are non-metastatic and non-relapse, the T-cell non-Hodgkin's lymphomas, and the acute lymphoblastic leukemias who are in remission. Otherwise, the acute lymphoblastic leukemias who have relapsed, who are on salvage chemotherapies, or who are on induction or reinduction, as I just described this case, acute myeloid leukemias, infant ALLs, intensive B-NHL protocols, high-risk neuroblastomas, those having undergone transplant, either autologous or allogenic, or the solid tumors who are on salvage chemotherapy, all fall in the high-risk category. So when we talk of febrile neutropenia, it is one of the most frequent and serious complications of cancer chemotherapy. It usually occurs in 10 to 50% of children with solid tumors and in 80% of those with hematological malignancies. But clinically documented infections occur only in around 1/3 of these children. So you may not find a focus in approximately 2/3 of these children. Of late, the gram-positive pathogens which have become resistant like MRSA and VRE are frequently found. And so also the fluconazole-resistant Candida strains like Candida krusei and glabrata have become very common. But usually the fungal infections in a case of neutropenia occur 1 week after the neutropenia sets in. So they don't present upfront with fungal infections. So we never think of fungal infections to begin with. Now, how do you define febrile neutropenia? There is a definition for these children. You just cannot say that any child who comes with fever has got febrile neutropenia. It is defined as a single oral temperature of 101 or 38.3 degrees, which is one or more, or a temperature of 100.4, which is sustained over a 1 hour period. And it's preferable not to do the axillary and the rectal temperatures. As I told you, that rectal intervention should be completely avoided in these children. When we talk of neutropenia, the absolute neutrophil count should be less than 500 cells, or it should be expected to decrease in the next 48 hours to less than 500 cells per cubic millimeter. Now, how do we calculate absolute neutrophil count? It's the amount of neutrophils present in the blood, which includes both the mature and the immature ones. And so both the mature neutrophils are the segmented cells, and the bands, which are the immature neutrophils. And when you calculate it, there is a formula of percentage of mature neutrophils and the percentage of bands divided into the total WBC. Normal range in all children should be more than 1500. And you categorize them as severe when the white cell count, the ANC drops than less than 500, or there is profound when the absolute neutrophil count is less than 100. So normally when we give chemotherapy, we assume or we know that the neutropenia nadir happens around 10 to 14 days. And so that is the time when the children are very neutropenic and are bound to catch a lot of infections. But at times with certain chemotherapy, if you've given very, very high dose chemotherapies, you've given something like topotecan or TVD for neuroblastoma, then it may get prolonged even up to 4 to 6 weeks. So it depends on what agents have been used, but generally it's the second week when you expect the neutrophils to be completely low. And in the third week after the chemotherapy, you expect the rise in the neutrophils to happen again. So when you look at these children, there are a lot of factors which influence the risk of neutropenia and infection in these children. As I told you, the disease per se, whether if the child falls into a high-risk category where the child has leukemia, acute myeloid leukemia, or other factors as I described before, the duration and the severity of neutropenia, indwelling access devices usually are the primary culprit in these children, because if they have not been handled properly, there is a very high chance that there will be a bacterial contamination and the child will come with sepsis. Second is the gut translocation of these bacteria. Because of the heavy chemotherapy, they have a lot of mucositis, and so that causes the gut translocation of the gut bacteria. Whether if the child has received a transplant, then acute or chronic GVHD can also be a culprit. And if the child is on immunosuppressive treatment like high-dose steroids or total body irradiation, or has received anti-lymphocyte globulin, all these children can definitely come with neutropenic fevers. Now, as we discussed, the common pathogens, the positive pathogens are the coagulase negative Staph aureus, including MRSA, VRE, Strep viridans, Streptococcus pneumoniae, and Streptococcus pyogenes. Among the gram-negative pathogens, E. coli, Klebsiella, Enterobacter, Pseudomonas, Citro, and Acetominobacter predominate. Now, So this spectrum usually keeps changing. Right now we have two children with Aeromonas, which is a cousin of Pseudomonas. So every time we have some new organisms with new fancy names coming up. So these children are so immunosuppressed that they can be they are exposed to a lot of gamut of all these new infections. Now, when you have, if a child is febrile and the neutrophil count is expected to be less than 500, in the next 24 to 48 hours, the child has come to you with febrile neutropenia. You do the neutrophil, you send the CBC, send the cultures, and start on empirical antibiotics. And don't wait for the counts to fall below 500. You know that this child is going to go down. Be a little preemptive and start the antibiotics. Don't start paracetamol unless you've categorized the child as having febrile neutropenia according to the definition. And if the child is on steroids, then there may not be classic signs of sepsis like fever and all that. Then you look at the SIRS signs like hypotension, tachycardia, tachypnea, and send the cultures and start the child on antibiotics. So if you think this child is high risk, you immediately hospitalize the child. What we do at times, the children who are staying close by, they come to our emergency, and then there are standing instructions that the moment the child comes in, you send across the CBC, send across the cultures from all the lumens. At the same time, do a peripheral blood culture also. Send for aerobic and anaerobic blood cultures and start them on empirical broad spectrum IV antibiotics within 1 hour of fever, and that's known as the golden hour. So the golden hour is the 1 hour as soon as the child presents. So we don't wait for the child to go to the admission counter, get admitted, come to the ward, and then we start all this. The child is instructed to go straight to the emergency. Now, as I told you, if the child is living too far away, probably you all at your hospitals and nursing homes can give this emergency care as we do it in our emergency downstairs. Now, empiric antibiotic is how do we decide what antibiotic to give? So, if the child is stable, you give a monotherapy with either a anti-pseudomonal beta-lactam, usually piperazole and tazobactam is preferred, or a fourth generation cephalosporin. But if the child is unstable, you can add another gram-negative antibiotic to the carbapenem and or glycopeptide. When do you do a gram-positive cover? When the child is in shock, has mucositis, or a suspected gram-positive infection. So in the sentence in red is very, very important. Immediate and empiric use of antibiotics is life-saving in febrile neutropenia children. But remember not to do it without sending the appropriate blood cultures immediately. So we add gram-positive coverage when we suspect a catheter-related infection, we suspect colonization with MRSA or cephalosporin-resistant pneumococci. The child is hypotensive, has soft tissue infections or severe mucositis. So this is the algorithm which we follow, where if you have categorized the patient as low risk, probably you can give oral antibiotics like augmentin or ciprofloxacin and monitor the child. But if you think that the child is high risk, if the child is stable, you give a monotherapy with cefepime, ceftazidime, or carbapenem. If the child is hemodynamically unstable, you can add an aminoglycoside to that. And you need a gram-positive coverage of vancomycin, as I discussed in the previous slide, and then you reassess the child after 3 days, 72 hours. Now, so this re-evaluation is done every 3 days, whether you need to escalate or de-escalate the antibiotics. So if the child is not responding after 48 to 72 hours, you look actively for a possible source of infection, send repeat blood cultures, and upgrade your antibiotics. And if after 96 hours the fevers are still persisting, the child is not doing well, then probably, but if the child is hemodynamically stable, probably you don't need to upgrade. But then otherwise you need to add liposomal ampho-B or caspofungin. That's an antifungal cover that you need to do. You can do a CT chest and a USG abdomen. Optimize your fluids, electrolytes, nutrition, and blood component. Now, when do you stop antibiotics in these children? If the child is afebrile for 24 hours, the blood culture is sterile, and your marrow is showing signs of recovery, then probably you can think of stopping the antibiotics. Now, GCSF, normally if the child is in remission, like in reinduction, we know that he has been minimal residual disease negative at time point 1 and 2. We would not hesitate to increase his counts by giving GCSF. But if a child comes during induction, when the marrow has not been eradicated of all the blasts, we will not be using GCSF at that time, at that point of time. Now, we can also use granulocyte transfusions. So in extreme cases, we do use granulocyte transfusions. Usually we do that in severe aplastic anemia patients. Rarely do we use them in leukemic patients or in children with solid tumors. When in especially if you have a child with renal impairment, you have given nephrotoxic chemotherapy like cisplatin, like in a hepatoblastoma, osteosarcoma, or a medulloblastoma, or if the child has a single kidney, then you should be wary of your antibiotics and check that you are giving in nephrotoxic, not giving nephrotoxic doses to these children. And if you have an established renal impairment, then ciprofloxacin with ceftazidime or with piperacillin tazobactam are good empirical antibiotics to choose. Now, so we've come to a stage where the child we have assessed, we have given the frontline treatment appropriately, and now we need to assess after 3 to 5 days of treatment. And if you've managed to identify what the etiology is, then you can adjust according to the appropriate treatment. But if you have not identified the etiology and the child is low risk, probably you can change to oral antibiotics if you've been given IV antibiotics. Or if it is a high risk, then you continue the same IV antibiotics. So always remember that you should, if you are dealing, if you have referred a patient, oncology patient, and you are the primary nodal physician, always be in touch with your primary oncology doctor whom you referred to, because there may be specific recommendations for empirical therapy for individual patients. They may be having susceptibility to certain antibiotics and not having certain. So a shared care is always very important. So it's always good to be in contact with the physicians and with the oncology unit. The empirical regimen is the same irrespective of the previous antibiotic courses. So you can start with the same antibiotics you had used last time, unless you know that there is resistance to these. So that will help you in deciding the antibiotics to use. And if you are suspecting meningitis, then meropenem is a good choice, provided you have done a CSF before instituting the meropenem. And cotrimoxazole prophylaxis is usually given to leukemic patients, ALL patients on weekends. So to summarize what I have said till now, that you start with empirical. So that when a child with febrile neutropenia presents, the first thing is that you examine the child, look at the Oscar signs, then you take the cultures, the CBC, and you start empirical antibiotics. After 72 hours, you reassess whether if there is a resolution of fever or not. If yes, and the child is low risk, you can switch to oral antibiotics and then gradually discharge the child. If it's high risk, you can continue the IV antibiotics. If there is no resolution of fever, you reassess the child. If the child is clinically not deteriorating, you continue the same antibiotics. And probably on day 5, you can add an antifungal cover if the neutropenia persists. But if the child is getting better, you can modify. If the child is the clinical deterioration is happening, then you can modify according to what you have found and add an antifungal cover. So when do you stop antibiotics in standard risk patients? If the blood culture has turned negative, you can stop aminoglycosides. If you are on a dual cover, you stop the aminoglycosides at 48 hours if clinically stable. And once the child is afebrile for 24 to 48 hours, you stop all antibiotics once the temperature is less than 37.5. But if you have a proven blood culture, then you need to give at least 10 days of appropriate antibiotics. And the child should be afebrile and with negative cultures and with rising neutrophil counts before you stop the antibiotics in a culture positive patient altogether. So I just heard Dr. Pooja talking about the shock. So these sepsis, if not treated properly, you are heralding for a septic shock. And then this child is definitely going to go to the ICU, and then it's going to get very, very difficult. So what are the red flags for septic shock and febrile neutropenia? So if this child, if he is lethargic since 3 years, and then another 3 hours, if he's going to be referred to SRCC, he's going to be 6 hours before he reaches the emergency at SRCC, he's definitely going to land up in the ICU in a septic shock. And so, if the child has reduced spontaneous movement, somnolence, agitation, blood pressure, systolic and diastolic are below the age norm, the mean arterial pressure is less than 50, there is pain, the urine output is he's having oliguria, then this is definitely going to heading towards septic shock and is going to go into the ICU. So these are the other signs which we can see the respiratory rate, the child is not maintaining the saturation, and there is tachypnea, or there are skin lesions, abscesses, fissures, the CRT is prolonged, there is decreased peristalsis, there is stiflitis. All this is saying that the child is going towards septic shock and needs to go to the ICU, which we should try to prevent in these children as far as possible. How do we prevent? It's by hand washing, restriction of visitors and overcrowded places, handling of IV lines, aseptic care in the form of mouth, skin, perianal. So all our children are on chlorhexidine mouthwashes, candid mouth paint, and sitz bath twice a day, and chlorhexidine mouthwash, candid mouth paint thrice a day. This has to be reinforced again and again every time the child comes to us, because children normally want to avoid doing all this. Isolation and barrier nursing care is very important. Visitors should not be allowed. It should be reinforced that relatives should not be coming and meeting these children, and they all should not be going to crowded places. Boiled water and well cooked home food is what has to be given. We also tell them not to eat salads which cannot be peeled and fruits which cannot be peeled, because then there are a lot of bacteria, pesticides on the outer core, like eating grapes, we usually don't allow. This is one example. So, and like a raw tomato is also not allowed. So, this has to be told to them specifically while they are on chemotherapy. So, to summarize, febrile neutropenia is a medical emergency. Absence of fever with signs of SIRS like hypertension, tachycardia, tachypnea in a child receiving steroids requires prompt intervention. Follow the OSCAR as far as examination is concerned, that is the oral cavity, the skin, the catheter site, the anal region, and the vital signs. Follow the 1 hour golden rule. So please institute IV antibiotics within 1 hour if you see a febrile neutropenic child on chemotherapy. Rectal examination has to be avoided, but you have to first take the CBC and the appropriate blood cultures before instituting IV antibiotics, and be in touch with your pediatric oncologist for shared care. Thank you so much. If any questions, more than welcome.
Okay, so coming to the last topic of the day. So I'll keep it very brief and short. So we'll be discussing status epilepticus today, which is a very important topic clinically. So yeah, so status epilepticus is one of the most common childhood neurological emergencies. Practically speaking, any child coming to the casualty with active seizure is considered to be in status epilepticus, or if the child has repeated seizures and there is no episode of regaining of consciousness between two seizure episodes, the child is said to be in status. So, according to the International League Against Epilepsy, which gave the guidelines in 2015, they have introduced two terms, T1 and T2. T1 is the time duration after which active intervention has to be taken, and T2 is the time duration after which there are potential neurological risks. So they have divided status into two types: generalized convulsive status epilepticus and focal status with impaired consciousness. So T1 in cases of generalized convulsive status epilepticus is 5 minutes. So we can wait till 5 minutes for the seizures to self-abort. If the seizures are not abating in 5 minutes, then we have to give IV or intranasal benzodiazepines. And if the seizures continue for more than 30 minutes, then we can suspect neurological consequences. And for focal, the T1 and T2, they have given 10 minutes and more than 60 minutes respectively. So, etiology, there are a lot of things which can lead to status epilepticus, very common being acute infections, stroke, toxicity, electrolyte imbalance, hypothermia, blood sugar levels fluctuation, trauma, hypoxia, febrile seizures, neuroinfections like HSV infections or Japanese encephalitis and multiple IEMs can lead to status epilepticus. Remote remote causes might be any previous brain scars or brain malformations which were there. Progressive causes can be neurodegenerative disorders and tumors, poor drug compliance, and very resistant epileptic syndromes like Lennox-Gastaut syndrome or Dravet syndrome are very known to cause status epilepticus. And they have introduced two new terms, NORS and FIRES. NORS is new onset refractory status epilepticus, and FIRES is febrile infection related epilepsy syndromes. Okay. So talking about refractory status and super refractory status. So refractory status epilepticus is defined as status epilepticus that fails to respond to adequately used two anti-seizure medications, first being a benzodiazepine and second being a non-benzodiazepine medications. Also, they have defined refractory status epilepticus as any seizure lasting for more than 60 minutes. Super refractory status epilepticus, status that persists for more than 24 hours or more after initiation of third line medications, which are IV anesthetic medications, or recurrence of seizure during withdrawal of these anesthetics. Talking about NORS, new onset refractory status epilepticus, is a condition without a clear acute or active structural, toxic, or a metabolic cause in a patient without active epilepsy or any pre-existing neurological disorder. It is a clinical presentation and not a specific diagnosis. FIRES is a subset of NORS. FIRES being febrile infection related epilepsy syndrome. These are usually seen in school-going children, and they are very common in males as compared to females. Usually, the child has a preceding upper respiratory tract or some kind of infection with fever, and after that the child gets a status epilepticus. So NORS with a prior febrile infection between 2 weeks and 24 hours prior to the onset of refractive status, with or without fever at the actual onset of status epilepticus. As we discussed, it's a subcategory of NORS. So we'll be talking about just the active management, pre-hospitalization, and in the hospital. So at home, the child should be, or in the casualty, the child should be put in a recovery position, as we can see in the image, to prevent aspiration. The parent should be counseled and taught about this recovery position and the importance of rescue medicines. So as discussed, we can wait for 5 minutes for the seizures to self-abort. If the seizures are lasting for more than 5 minutes, we need to give the child anti-seizure medications. The most commonly being used is midazolam. Midazolam can be given buccal or intranasal, the dose being 0.2 milligram per kg per dose or 2 puffs for every 5 kg weight. Lorazepam can be used intramuscularly or intranasally, the dose being zero point 0.1 to zero point 0.2 mg per kg per dose. Diazepam can be used per rectal, the dose is 0.5 mg per kg per dose. Very important to monitor blood sugars. Once a child is in the casualty, airway, breathing, and circulation should be taken care of. And if the seizures are not subsiding or lasting for more than 5 minutes, after giving appropriate medication, child should be shifted to a hospital as soon as possible. So management in the hospital. So as soon as the child arrives, it is very important to take care of ABCs, your airway oxygenation, breathing, and circulation. A quick history becomes very important, and a short neurological examination. Also very important is any history of previous anti-epileptic medications. So as soon as the child arrives, very important to take blood samples for a CBC, sugar, calcium, magnesium, and your serum electrolytes, ABG or VBG, if possible. If the child comes with fever, it's very important to collect cultures and management. Preferably secure an IV line. We can use either of these drugs: lorazepam 0.1 mg per kg, diazepam 0.2 to 0.3 mg per kg, Medas 0.1 to 0.2 mg per kg, maximum being 5 mg per dose. If IV access cannot be established, which is very commonly encountered, then we can also use IV intranasal buccal or parectal routes. So if the seizure duration crosses 5 minutes, the child is labeled to be in status epilepticus. So preferably the child should be kept in the PICU till the child is stabilized. Signs of raised ICP should be monitored and treated appropriately. If seizures persist, the child can be started on IV phosphenytoin, which is preferred over phenytoin. Phosphenytoin being 20 mg per kg of phenytoin equivalents with heart rate monitoring. We can repeat IV phenytoin or phosphenytoin after 10 to 15 minutes of the previous medication. If the seizures still persist after 20 minutes of medication, it is very important to watch out for signs of raised ICP, whether the child is having rhabdomyolysis, any arrhythmias, sepsis, or any hypersensitivity to your medications. So continuous EEG monitoring is advised for non-convulsive status epilepticus. If the child is still seizing, we can always use IV valproate 20 mg to 40 mg per kg or IV phenobarbital or IV levetiracetam, which is most commonly preferred nowadays, the dose being 20 preferably. If the seizures last for more than 60 minutes, child is supposed to be in a refractory status epilepticus. So in this case, it becomes very important to rule out neuro infections, specifically viral infections like HSV1, MRI brain plus contrast, or a CT, whichever is feasible. Very important to rule out autoimmune causes, especially anti-NMDA, autoimmune encephalitis. Metabolic and genetic studies depends on the availability of resources. Now the child has to be given general anesthetics to achieve burst suppression. So most commonly used medication is either Medas or Propofol. Medas has to be started at 0.2 mg per kg IV bolus and followed by an infusion of 1 microgram per kg per minute, which can be increased to a maximum of 30 mics per kg per minute. Or we can use propofol loading of 1 to 2 mg per kg, followed by a continuous infusion of 1 to 2 mg per kg per hour, max being 5 mg per kg per hour. Most commonly, most setups usually use Medas or propofol as compared to other medications. If the child is still seizing after 24 hours, the child is said to be in super refractory status epilepticus. Preferably shift the child to a higher center where there is a neurocritical unit to be managed usually by a pediatric neurologist with intensivists. So in these cases, everything the treatment depends and varies case to case situation. Ketogenic diet is being tried and has been tried in many institutes. Should be started as early as possible by expert dietitians. Some institutes prefer giving immunotherapy in the form of IV prednisolone or IVIG. Other very rare treatments include vagal nerve stimulation, therapeutic hypothermia, and epilepsy surgeries are being conducted these days, but they have very high chances of morbidity. So, take-home messages: caregivers should be taught first aid, including the recovery position and use of rescue medications. Very important to counsel the parents how to manage an active episode of convulsion and not to worry and shift the child as soon as possible to the hospital. To the hospital. So we have to remember that time is brain. Thank you. If anyone has any questions, kindly let us know in the chat box, or otherwise we'll wrap up the session. Thank you so much.